and depth. Regarding perforation, cannot be helped by mitral clipping, and if the patient has cleft, we have done some cases with cleft. However, you shouldn't go for doing cleft mitral valve.
He's entering again.
Okay. This is the device. This is the controls to control the knobs or the grippers and the arms. This is the clip itself. These are the arms of the clip. These are the grippers. And this is the spare that is inside, coming out of the sheath. And between the arms and the grippers, the native mitral valve leaflets will be caught here, and then the arms will close to sandwich the mitral leaflet. This animation is showing how the procedure is being done after transeptal puncture. This is the guide catheter, this is the sheath, and this is the clip in closed position. This is the comedine ridge, left upper pulmonary vein, left atrial appendage, mitral valve is down. It's a steerable sheath, so usually they face the mitral valve. This is the patient with functional mitral regurgitation, that's why there is no coaptation. And then the mitral clip arms will open, and then we have to check the perpendicularity to make sure the clip is really perpendicular to the leaflets, as you can see from here. And this is not an easy step, especially if you're using two-dimensional echo. And then with color, we need to make sure the clip is really hitting the regurgitant jet, wherever it is, central or lateral or medial. And then the clip will dive down, and then grasp the leaflets, grippers down, arms up, and then we will assess. If no MR, well and good. Otherwise, we can reposition the clip or put more than one or even more mitral clip. So if the high risk for surgery, the cardiologist will do it. Before transeptal puncture, you have to assess the mitral valve for the anatomy and for the severe mitral regurgitation or significant mitral regurgitation. It is not only about the color or the pretty image, it's about the data that you can get from this 3D volume. By the MPR, you just put your lines exactly at the ostium of the mitral valve during systole, and you get the so-called 3D vena contracta area, which I believe this should be the standard of looking at the regurgitation, because as Martin very nicely showed us about the tricuspid valve, it is not a circle, it is not it is not symmetrical along the coaptation line, so it's very bizarre shape. You shouldn't use BISA for that. You shouldn't use the 2D vena contracta for that. It is not only about assessment of the severity of MR, but we have shown that the vena contracta area can estimate or predict the number of mitral clips needed during the procedure. We have done some work on that. Actually, that was my MD thesis, and we could show if the length of the vena contracta area is more 1 centimeter, this patient will definitely need more than one mitral clip, and if the area itself is more than 0.2, this patient is more likely to get more than one mitral clip. This helps you in the strategic planning of the procedure. If you know that you are going to do at least 2 mitral clips, it is not good to clip in the center. Maybe you start medially first because it is more difficult, and then put the other one laterally. The technical people will know what I'm speaking about. Again, looking to the regurgitant orifice itself will help you too much to, again, understand which areas to grasp. Here I'm looking to the mitral valve from the LV aspect. You can see a central mitral regurgitation. So here I will grasp in the center. This patient has medial mitral regurgitation orifice, so I'll grasp here medially. And this is like a full chamber view. You can see a major lateral jet, tiny medial jet. So grasping in the middle or medially will not help this patient. In that case, I have to grasp at this particular point. Look for any effusion to start with, because if you develop any effusion in the middle of the procedure, you have to warn everybody, and sometimes the operation will be aborted. X-plane is very helpful as well to see the direction of the jet. Checking the left atrial appendage is very important. Many of those patients have left atrial hypertension, atrial fibrillation. Maybe you will have thrombus before you start putting your wires and everything, so it's better to assess the appendage. This is an on-fast view for the appendage by 3D-TEE. You can see it is oval, left upper pulmonary vein here, and this is the lateral commissure of the mitral valve. With one volume, you can assess that with the MPR, scan the appendage from side to side, and check if there is any thrombus hiding somewhere. During the procedure itself, you have seen the transeptal puncture many times in my talks, but again, quickly, this is how to do the lateral maneuver to get the anatomically oriented septal view from the right side. Starting from the bicaval view, and then activate the 3D zoom. The most important point is to stop at the ostia of the vena cava, then rotate anti-clockwise, which is RA, and then tilt left, TLE, reduce the gain down. This brown color is the blood signal, decrease the gain, and then you will have a very clear view of the septum from the right atrial aspect. Transseptal puncture, this is the catheter coming from the IVC towards the SVC. So here is anterior, the root, ascending aorta. This is the fossa, the faint part. And so here is superior, inferior, anterior, posterior, everything in one view. Now the intervention started to pull the catheter from the superior vena cava towards the fossa, and he can orient himself to impinge on the septum and do the tenting. After he do the tenting, like that, and we have published that as we said, you can see from the biatrial view to check where is the tenting before allowing him to puncture. This is from the short axis view, short axis bit, to show you the anterior posterior relationship of the tenting point. So we have to be in the posterior part of the septum. As we said before, you do not need to puncture anteriorly, and the height is very important. In MitraClip, a golden number is 4 centimeters to allow you to navigate with the sheath to come down, because if you are too low, you may not be able to navigate the sheath down to touch the mitral valve and bend your sheath. And if you are too high, even if you could bend your sheath, you may not be able to cross the mitral valve. So you need to be somewhere between 4, unless the patient has flail or degenerative mitral regurgitation. In that case, you need to go a little bit higher, or functional mitral regurgitation and there is tethering. In that case, you may need to go a little bit lower. But 4 centimeters is widely accepted. If you are okay with that, you can go ahead and puncture. Then the guide catheter will be there. This is the equivalent view by 3D-TEE. You can see here is the right side. The catheter is crossing the septum at the roof of the left atrium. Mitral valve is here, and this is the comedine ridge, below which is the left atrial appendage. Now wiring the pulmonary vein. This is live, so even you can tilt it like what I will do here to show the interventionist where is the appendage, where he shouldn't go, and where is the left upper pulmonary vein, where he should go and put his wire. This is after cannulating the pulmonary vein. The battery is 10%. I got all the technical problems in my talk. Okay, yeah, thank you. Now the sheath is advanced and the clip is still closed and crossed over the comedine ridge inside the left upper pulmonary vein. This is the equivalent view again. The guide catheter is still here. This is the sheath, and the clip is in closed position above the comedine ridge. Mitral valve is down. Now bending the sheath, pointing towards the mitral valve, and then explain after opening the MitraClip arms. This is a very good view to start with. Usually we start by the commissural view and then explain if you have it, and then you will have the long axis view with the 2 arms seen in the long axis and one side is seen in the commissural view. Again, this will depend on your mental reconstruction. However, this is a very easy step if you are using 3-dimensional echo, because everybody in this room will know this is not perpendicular. It needs some counterclockwise rotation. Okay. Okay. So even movement from side to side, very easily appreciated and monitored by 3D. If you are doing this using 2-dimensional echo, each millimeter of motion, you will lose the clip, and then you tell the interventionist, stop, let me get you back into my screen. But here the patient is breathing, he's doing everything, the clip is moving, but you still see everything without any manipulation. Now we will put color to make sure that we are really hitting the regurgitant area, and now he's checking the trajectory of the clip. Sometimes, even if you are on top of the regurgitant area, once you cross the LV, the clip will go more medially or more laterally, so it's better to appreciate the trajectory, how the clip will behave once it dives inside the LV like now, okay? This is a very reassuring view for us. That means we are really dissecting the regurgitant jet, and then the clipping motion should be done on long axis. It's a 2D step. In this clipping step, the anterior leaflet was in, but posterior leaflet is out. Failed gripping. So we'll do this again. Grippers down, arms up, anterior is in, posterior is in, successful grasping. After assessment, there was some medial lateral jet of mitral regurgitation. We consider it in this case significant. We have to measure the mean gradient to make sure it is not reaching 5 millimeters of mercury as mean gradient, otherwise we should stop. With the first clip in position after release, the sheath, the guide catheter is still there. Introduce the second clip the same way the first one was done. Positioning of the second clip is easier using three-dimensional echo, of course, and fluoroscopy also helps a lot in that. So after second grasping, there was some stasis. In this case, this patient has atrial fibrillation corrected by heparin dose and assessment of the grasping. It's a good idea to measure the length of the posterior leaflet and the anterior leaflet before at the grasping view, and then to measure them after to see how much you grasp it, you caught by the MitraClip in order to make sure that you are really took a good punch of the leaflet. If you are happy, you can ask the interventionist to release. This part is like a needle, exactly is like a needle. If you have to monitor the behavior of this step, otherwise it can touch the comedian ridge or any part of the left atrial wall and causing perforation and all the rest of it. So in 2D, it's very tiring because if he moved, you will lose him, and then you tell him stop again. But in 3D, you can see everything. He's just taking the catheter back, and you are fine. That was the final result in this particular patient. Double orifice mitral valve from the left atrium or from the left ventricular aspect. You can see here two clips side by side. The two orifices are there. This is the LVOT. This is just to compare the patient before and after. So in conclusion, three-dimensional TEE and two-dimensional TEE is crucial. This is an echo-guided procedure. It is very difficult to do it. It is impossible actually to do it without transesophageal echo. It creates a common language between you and the interventionist. I'm speaking about three-dimensional echo. And you don't need actually to go to the stomach, because by simple motion of the trackball, you can see the mitral valve from the left atrium or from the left ventricular aspect without the need to go to the stomach. Thank you so much.
Thanks a lot, Dr. Hani. As always, your lectures are really very informative to us. So now we are with Dr. Gilbert again. He's going to talk about the, he was connected? So, what interventionists need from echocardiologists during MitraClip. Dr. Gilbert, are you with us? Meanwhile, if you have any questions to Dr. You can have okay, to Dr. Hani till we join. As soon as we join, can we give Dr. Put the mics on, please. You can talk and بس من تحت الضغط من تحت. Okay. Yes.
No, we can reach the mitral valve, the clip system will go. But when you are so low, the clip opened, it comes back to the egg, but it does not reach the mitral valve. And when you have the clip is, the puncture site is very high, when you are inside the mitral valve, also you cannot grasp it because you are away with the leaflets. You just go, but you do not cross that gluten line of the leaflets.
Okay. معلش يا دكتور رضا, can we هذا we'll continue with you after. Okay. Okay. Thank you, Dr. Rida. Now Dr. Gilbert, are you with us now, please?
Can you hear me?
Yes, yes, we can. Go ahead, please. Thank you.
Okay, great. Thank you. So